I am one of the steering committee. I'm a member of the steering committee of the COVID-19 Consortium, Cancer Consortium. Here in the US, we are now an international consortium with members from Europe and South America. This has been formed over the last month, essentially, in the setting of the coronavirus pandemic and the recognition as oncologists that cancer patients are an extremely vulnerable population because of their disease, their cancer, the types of treatments they're receiving, and the fact that at least the data that we have so far indicates that they're more susceptible to the coronavirus infection, but even more importantly, they are more likely to suffer serious life-threatening complications from COVID-19, including hospitalization, intensive care unit placement, ventilator support requirements, and unfortunately a higher risk of mortality. So cancer patients, particularly those going through cancer treatment, are one of the more vulnerable populations, and we wanted to track the experience of our patients throughout the United States, and as I said, now in Europe. Of course, there's a similar registry being run in parallel in the UK, and this is a global effort that we're a part of to gather as much information over a short period of time to inform clinical decisions in the care of cancer patients, and hopefully lay the groundwork for the clinical trials that are coming of new coronavirus treatments, and eventually the vaccine trials that are just getting launched. So we think all this information will be helpful to clinicians in management, as well as providing a framework for these clinical trials that are coming. Well, again, this is a multi-institutional and now multinational coalition. And our aim is pretty straightforward. Again, it's to gather as much information about the makeup of the cancer population that is infected with the coronavirus, look at their comorbidities, other illnesses that they might have that could complicate their course, see how they're being treated, whether it's being treated for the cancer, and of course some cancer treatments make them more vulnerable, as well as how patients are being managed and treated for the virus itself. Of course, even before the clinical trials are launched, clinicians are using anecdotal experience to offer different treatments and support. And then, of course, we want to look at what makes a difference in terms of clinical outcomes, what patients are surviving, coming off the ventilators, being discharged from the hospital. And at the same time, because these are cancer patients, many of whom are on treatment, we're trying to assess how oncologists are managing that cancer treatment. We know there are some situations where the treatments are being delayed or postponed, other situations where they're being modified to provide less of a risk to the patient, maybe requiring less contact with the healthcare system, which not only reduces their risk of exposure, but frees up healthcare resources for fighting the pandemic on a broader basis. So, and we do know in many places that the hospital and healthcare resources are being stretched, and in some cases are being exceeded, so that there's a very unfortunate decisions being made as to who can get treated and who does not. Very difficult ethical issues. So all this, we think, requires data. Information is power, and we're trying to provide that power to clinicians as well as investigators to do the necessary studies to eventually get us out of this pandemic. Right now, we have close to 100 centers participating. Many of them are large university or comprehensive cancer centers. Others are practices, generally larger group practices. A lot of oncology care in the States is provided by the community centers. And then again, we have centers from Spain and other countries throughout the world. And we have been adding additional centers as we go on, literally every day. At the moment, we're going through the first analysis, the first 30 days of data that we have on these patients, and we'll report that out shortly. But the process continues. You want to look at 60 days, at 90 days, and see how patients do over the long term. But for right now, we're looking at the very initial experience here, and in fact have hundreds of patients with cancer and COVID-19 test positive for the infection that we're analyzing at the very moment and will soon be reporting. Again, there's nearly 100 centers participating. We're all putting our data into the same data warehouse, which is housed at Vanderbilt University. This whole project spawned out of discussions on the internet, almost like a crowdsourcing initiative that we were all frantic to get more information about managing cancer patients with coronavirus infection. The initial lead came from Dr. Jeremy Warner at Vanderbilt, who in Vanderbilt University's, which is the institution that houses this REDCap system, which is used in more than 4,000 institutions worldwide. So it was this ability to capture data through the web, capture it in a single data repository, and that's what's being analyzed at the present time. So all these institutions, they're inputting the data into this data system at their local institutions, but it all gets shared with the central data warehouse at Vanderbilt University. And this is unique. You know, I've been doing cancer research for many years, and this is the first time we've been able to launch a study so quickly and so broadly across the US and now globally to answer an urgent series of questions about these patients. So our initial results, again, they're still being analyzed. I can only tell you at this point, certainly there's many things that we are already seeing in terms of patterns in the data, consistent with what others have shown, which is older patients with cancer and COVID-19 infection are more at risk for hospitalization, for emergent admission to the intensive care unit, and a higher risk of mortality. We're also seeing, of course, patients with other medical conditions, many of which have been described, like diabetes, hypertension, and so forth. In addition to their cancer, those patients are also at greater risk for complications that come with this territory. And of course, cancer is a disease largely of aging. Older patients are more likely to have cancer and are more likely to have these other conditions. So it's like the perfect storm for this COVID-19 infection to impact with dire consequences in cancer patients. We also are seeing, and again, there'll be more details as we continue to analyze the data, that patients are being treated in many different ways across the US. And some are getting off-the-counter medications, some are getting drugs approved for other indications, but have not been well studied in this setting. And of course, some patients are going on clinical trials, which is what we're encouraging, antiviral therapies and other ways to suppress the most serious consequences of the COVID-19 infection, which is the acute respiratory distress syndrome, which puts patients into respiratory failure, requiring ventilatory support, and again, unfortunately, all too often results in early mortality. But so we're seeing many of these same patterns. We are seeing some unique things come out of this as well. but because we're embargoed, this is being submitted for publication this week. I can't really go into the detail, but we are going to try to disseminate this information as rapidly as we can to the professional community, again, to both better inform their management of patients at the point of care, and inform our groups doing clinical trials as to how best to structure those trials to be most effective at treating the COVID-19 infection. Yes, our requirement for accrual to the registry, which, as I said, is approaching 1,000 cancer patients with COVID-19 infection, is that they have to be test positive. In other words, they have to have cancer and they have to have a documented COVID-19 infection. There's no requirement for symptoms or for hospitalization necessarily. But of course, the patients that are being identified and submitted to the registry are often patients who have come to the hospital or have developed symptoms. That's what brought them to the attention of the healthcare system. So I won't argue that this is a broad, random sampling of cancer patients in the community. I will say at our own institution here at the Fred Hutchinson Cancer Research Center in the University of Washington and our outpatient clinics at the Seattle Cancer Care Alliance, we are testing broadly. We are assessing all patients as they come for an appointment in the clinic or in the hospital. They're being screened carefully. And we're basically working under the assumption that any patient may be infected with or without symptoms. And through that, as well as our state was, of course, the first state in the US to have a COVID-19 infection diagnosed just outside of Seattle. Also, unfortunately, the first state to report a death from COVID-19 infection. And we saw an outbreak very late February here in Western Washington state that made us initially the epicenter for COVID-19 infections in the US. That's what prompted all of this action on our part to get in to help launch the CCC-19 consortium. However, the good news from our standpoint is that prompted our institutions, our healthcare system, and our government, the governor of the state, our legislators, our mayors, to put into prompt action protection measures, stay-at-home policies, and basically social distancing. And because that was put into place very early, well over almost 6 weeks ago now, we have seen a fairly significant downturn in what were the original projections. So while we were #1 in terms of incidence 6 weeks ago in the US, I think we're down around number 15 with many other states now that have much higher incidence and mortality rates than here in the state. So we are hoping by early May, mid-May at the latest, to begin to start loosening some of these restrictions. But I must say it was a bittersweet scenario that we were the first impacted and the first to become the epicenter in the US, but the prompt action by our healthcare system and our government, I think, has minimized the consequences of this in the state of Washington and allowed us to get ahead of flatten the curve. And while our healthcare system was stretched, it has not been overwhelmed or exceeded. And in fact, the governor just recently sent back 400 ventilators to the US national stockpile because we felt there were other parts of the country that needed them most. And we also have closed one of the temporary hospital facilities. So all this means that we believe we've gotten ahead of this as much as possible. It's not, we're not through it yet, People on the front line in the hospitals are still battling this on a daily basis. At the moment, we have well over 100 COVID patients in our university health system, and probably around 30 on ventilators, but or at least in the intensive care unit. But the point being that the projections initially were that we would be far above where we are right now. And by social distancing, closing down temporarily all but essential services, and compliance by the population, which has generally been very receptive, wanting to protect themselves, their loved ones, and those around them, it all has worked very effectively. Unfortunately, again, there are other parts of the country, New York, New Jersey, and Chicago now that are very much affected, but we hope that they too will get through this, as we all will, and get back to life as much as normal can be. So the process is straightforward. Going to the website of the CCC-19 Consortium. There's a link there to register. Some basic information is gathered about the institution, who would be the point person to do with this. As I mentioned, virtually all major healthcare systems in the US participate in this REDCap data management, data capture system. And so once all those are clarified, then permission is granted to add them to the consortium. And while we have around 100 currently registered, there are probably another 40 or 50 that are in the process of going through this. So these get approved by either the Vanderbilt IRB, Institutional Review Board, or in our case, we had our own local university IRB approve the protocol for this. But either way, once you have approval, you can go ahead and start putting the data in at your local institution. It's put in on the web. It's a survey form that's completed, and then a data transfer agreement allows that data to be moved to the central repository where it is undergoing at the moment analysis. We've learned a lot here in Washington State and throughout the country now as we participate in this program. Although again, I think we are doing better than expected here in Washington State. This problem is a global one, and it's one that is going to affect many additional parts of the United States. There are many rural areas of the US and other parts of the world, including Africa, Middle East, Asia, where this pandemic is yet to hit its full force. And I think everyone, and particularly those that are involved in healthcare delivery, need to be prepared for this. We, like everyone else, have had real strain on protective equipment. We have been able to get the ventilators that we need, and our bed capacity has, with adjustment, has been able to cope with the illness here. Many places, though, that healthcare capacity has been exceeded with, again, difficult decisions being made. But protective equipment, and then finally, for us to transition to anything beyond COVID-19, any kind of new normal, we need broad testing. And testing has been a real challenge. There were really problems here in the US getting testing out. Initial testing was unfortunately not terribly good, and there's been readjustment. We had the advantage here at the University of Washington as we were, once the FDA allowed us, we did our own laboratory-based testing. And again, we've been using that as well as now commercial testing to broadly test the patients coming to the healthcare system as well as our healthcare providers. But testing is still a challenge. We need to continue to ramp that up. And it's not until we really have broad, almost universal testing will we have a true picture of the scale of this problem and where the next hotspots are going to be. So I think the message that we would send is be prepared. You know, if you're lucky and you don't get impacted severely by this, you may say, well, why do we do all this? But it's far better situation than not being prepared and then being left with extraordinary difficulty managing these patients and further loss of life. So we would encourage all corners of the US and other parts of the world to be prepared for this. And again, call upon broad access to testing. We are also encouraging places that have imposed social distancing and essential service only availability to continue for the time being until we see a clear, continuous downturn in the incidence of this infection. Otherwise, we're going to see a second or third wave of this infection come through if we prematurely open up to business as usual here. So obviously controversial, particularly here in the US, but it's the long-term effects will be far less if we continue to be very careful and just make this assumption that anybody can be infected, including yourself. We're calling on people to be masked when they're out in public, in any kind of crowded situation. We just need to continue these measures for now if we're going to avoid those future waves of this infection. I give my great thanks to both my local colleagues that have been involved in our effort here at the university and the Fred Hutchinson Center that have been just outstanding contributors to our portion of this effort, and to the other members of the steering committee and all those institutions that are participating in the national and now global effort of CCC-19. It's the group at Vanderbilt, as I mentioned, Jeremy Warner, who kind of got this thing off the ground, colleagues from across the country. It's been a truly incredible effort that I've been proud to participate in. And we will continue to gather as much information because we do think that this problem is going to continue for a considerable time now. To our patients, we just want them to know we're trying to learn as much as we can very quickly so that we can get those treatment trials going, get the vaccine trials going, and they've already started. And the sooner the better, and eventually we'll all get through this together.